Hi, I'm Dr. Alan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island, New York City, and tri-state area. Today's topic is about intensive care medicine. We all have heard about ICUs. We all watch television and hear about all the bells and whistles and sounds in an ICU. I want to take the mystery out of it. And I have two marvelous experts who are going to help us. There's a generation that remembers when people had polio, which was a paralytic process, where they needed something called the iron lung in order to live. That was actually the first kind of respirator or artificial breathing device that we had that saved many lives, particularly in the 1950s. Respirator therapy, all other kind of therapies have advanced dramatically over the last few years. We've come a very long way. Our expert guests will help us take the mystery and explain all the alarms, bells, and whistles that you hear in the ICU, whether you have a loved one who's in the intensive care unit, or if you're just watching television and want to know what all those beeps and sounds are. Our guests, our esteemed and expert guests, are Dr. Jay Fenoim. He's Vice Chairman of the Department of Medicine and the Chief of the Critical Care Department at Richmond University Medical Center, and Dr. Keith Diaz, who's an interventionalist, intensivist, and director of the lung cancer screening program at Richmond University Medical Center. Welcome, and thank you all for coming.
Thank you, Dr. Perel.
We're going to talk about the ICU. So when we hear about an ICU, we say to ourselves, intensive care unit. There are a lot of different kinds of ICUs. There's surgical ICU, medical ICU, coronary care unit or CCU for heart patients, neonatal ICU, neurological ICU. What is an ICU and what's the criteria to be called an intensive care unit?
An intensive care unit, also called critical care unit, it's an area in every hospital where patients who are critically ill, patients who are seriously ill, needing life support measures get taken care of. Now, they go according to specialties at times. You know, you have this SICU, they call it surgical ICU, where trauma patients go to, patients post-operatively taken to. You have a neonatal ICU, as you mentioned, where you have the neonates taken care of. You have the pediatric ICU, where kids get taken care of, and CCU, which is the coronary care unit, where patients with things like myocardial infarction, individuals who have a heart attack, individuals who have an irregular heart rhythm, individuals who need pacemakers end up going to. And
As an intensivist, how specialized is your care? Meaning, would you be in the neonatal ICU, Dr. Diaz, or would there be a special kind of a doctor who's there who's specialized in that form of medicine?
There are different varieties of intensive care specialists, and each one of those units might have their own subspecialty, if you will, that might be have more specialized training just in a specific area, or there's some generalized intensivists that actually are in less specialized intensive care units that may cover more broad types of diseases.
So let's talk a little bit about what it is. So we said it's a special unit which specializes in very sick patients of all ages, from neonates to older patients, for people who need surgical intervention, medical intervention. So what kind of care is given in the ICU? Tell us a little bit. Let's take that mystery out. When someone goes into the intensive care unit, oftentimes the families aren't allowed in it all the time. And there's that whole mystery. What's going on there? So tell us a little bit.
I mean, most of what goes on in the ICU is you identify patients who really are critically ill. These individuals need very, very close monitoring.
Could you give us an example? Like what type of patient?
You know, you get somebody who comes in with a pneumonia, might not be able, you're concerned that this individual might deteriorate with time. So you bring an individual like that into the ICU where the staffing ratios are better, it's much better, where you have equipment that can monitor the patient's oxygen a little bit closer, more closely. That way, when things go wrong, you be able to intervene very, very quickly. Same with, say, somebody has trauma, you want to observe them, you bring them to like the surgical ICU, the reason you bring them there is you want to make sure they're monitored closely, and if something goes wrong, the interventions, some interventions will be done immediately.
So this is a team approach, of course. So what I'm hearing is that people who went in the emergency room or come into the hospital, who the doctors, when they come in, including help from the critical care specialist, feel that there's a significant likelihood that they're going to worsen.
Yes.
And those are the people. Because not everyone with pneumonia, goes to the intensive care unit. How do you decide how someone goes to the
There are certain scoring systems and predictors that we have that can help us predict what a prognosis might be. Generally, it depends on how many dysfunctions they may have, meaning that when someone is very seriously ill, they can have multiple organs that might be failing. They might have multiple blood abnormalities. So if they have other chronic illnesses, and all these might increase the potential for someone to actually deteriorate.
So in a sense, if someone comes in with pneumonia and their blood pressure is very low, or I think what you mentioned to me earlier, their electrolytes, their sodium, potassium are in tremendous flux, we're able to monitor people much closer in an intensive care unit.
That's right.
So that's important to think about. So let's talk about what you guys do. If someone comes into the intensive care unit, do they have to be, sometimes we see people always with monitors who are on a respirator. Do you have to be on a respirator or need breathing support to be in the intensive care unit?
No, not necessarily. A lot of the patients, some patients might end up that way, but a lot of patients get in there who do not need ventilators, they don't need respiratory assistance. Say somebody has a heart attack, individuals like that need to be monitored closely. They don't need a ventilator, they don't need respiratory support, but they might develop other abnormal heart rhythms, and the heart attack might get even worse. So you monitor those patients, not necessarily because they need a ventilator. You have somebody who has an infection and their blood pressure is low. You might want to bring them in so you can give them IV fluids, give them medications to support that blood pressure. They don't necessarily need to be on a ventilator.
You were talking about intervention. So in a sense, monitoring, and you guys are some of the best critical care people I know. And monitoring goes so far. So we're watching, the nurses are saying things. What is, as an intensivist, what kind of interventions could you do for patients? What kind of monitoring interventions, other life-saving interventions do you have in an intensive care unit that's different now versus, say, 20 years ago?
Well, one of the things that has necessarily changed is the role of intensivist in general. Probably 30 years ago or so, intensivists were really just becoming their own specialty. And part of that is now the constant assessment and reassessment ongoing with an actual intensivist that may be present throughout the day. So with all the monitoring that takes place, it's a physical, maybe visual reinspection of the actual patient with different frequent laboratory values coming through the day. There might be adjustments needed on medications and electrolyte or certain salt or potassium that needs to be readjustment. There may need to be blood products administered multiple times throughout the day.
When would you need blood products? For what kind of condition would you have to give someone blood products?
There are certain conditions that either may cause a person's bone marrow or the production of blood to not be appropriate, or there are also many conditions that might actually cause bleeding, such as certain hemorrhages. Oftentimes in trauma, patients may have disruption of their major blood vessels or organs that can cause significant bleeding, internal bleeding. Patients who sometimes have ulcers in their stomach or their duodenum, the bowel, could have significant bleeding and may require blood products at that time.
So if someone's bleeding or anemic, you can give them blood products. And if someone is bleeding, you can give them products to try to stop the bleeding. There are certain clotting factors that you have. Yeah,
I mean, there are clotting factors that we have, because when you lose blood, you lose factors, clotting factors as well. One of them is FFP, which is plasma, which you usually would give. The platelets also get given as well. those are all components of blood that need to be given to individuals who are bleeding when you give them a certain amount of red blood cells.
You were talking about cardiorhythmias before, Keith, and the question in my mind comes down to, if someone has comes in with a heart attack, you're really wanting to make sure that they don't have this fatal arrhythmia. So many times people will succumb not to the size of the heart attack, but rather to this disruption in the rhythm of the heart. And that sometimes we see those unusual things on television with beep, 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 something they call ventricular tachycardia, different more ominous rhythms. Tell me a little bit, there are medicines, the reason people are in the ICU is if they have one of these ominous rhythms and they're being watched. Tell me from start to finish, who's watching, who's getting a call, what do you do if someone has one of these bad rhythms? Do you put a pacemaker in? And tell us a little bit what happens, because I think people are interested in what's being watched.
I mean, as far as the arrhythmias are concerned, we monitor to see, then we determine whether it is stable or unstable. As being stable, it means your blood pressure is fine. So you don't need immediate intervention at that time. If you do, in that case, the team in the in the ICU would deal with it. If they have to shock you, give you medication, do an electrical shock to synchronize the heart or give you medication, that will be done. But most of the time, it doesn't get to that. It's an arrhythmia that is of concern. The critical care team calls the cardiologist. That's their specialty, or call the electrophysiologist to let them know this is what is happening, what are your thoughts, and then they can come in as well, just as we call it our specialists when we have issues that pertaining to special area, to their specialty. So we'll call an electrophysiologist who will come in and recommend what needs to be done.
So it's a team and everyone's available on really a moment's notice in the intensive care unit. What about a pacemaker? People always hear the term pacemaker. In an emergency situation, what do the intensivists or the doctors in the intensive care, how do they put it in? What do they do?
We have a few different types of pacemakers. In general, there can be what we call transcutaneous pacing, which really means across the skin, so that pads can actually be placed on top of a patient's chest, and we could effectively pace someone's heart in that manner. Or a transvenous pacemaker can be placed emergently, which is actually inserting a probe into a large vein, which actually gets wired down into the heart itself and actually can pace from inside. And that can be done fairly quickly within a matter of minutes in an experienced hand.
And that's what I think is so important when you're saying what could be done in the intensive care unit. There's monitoring, but there's also these interventions that in different parts of the hospital might take 15 minutes, 10 minutes to happen. Here they could be done very, very quickly.
Within minutes.
And that's a marvelous thing. Tell us about your training. What does it take to become a critical care doctor?
Okay, then let's just say it. Handle that.
Well, there's being a doctor starts at least with 4 years of medical school, and then depending on what your specialty is, has different years of residency. So in general, internal medicine intensivist would do 3 years of internal medicine, and then generally at least 2 years of a subspecialty intensive care training. It depends if you're going to be a different subspecialty, such as a neurointensivist, or they have cardiac intensivists, anesthesiologists can also be intensivists. So all of those have extensive training, I would say at least 5+ years after graduating from medical school.
So it's a lot of years and it's a lot of experience. And I'm sure that everyone over years learns more and more and sees different and more difficult situations. Let's go a little bit ahead. If someone's in the intensive care unit, a loved one, family member, is there any way to predict how they're going to do, what their prognosis is? You talked about scores and scales before. Is there any way, forget it intuitively, but anything medically that you think some people might do better or might do worse?
It really depends. A lot of patients, by the way, do well. Few don't, but you can always tell by the scoring systems that Dr. Diaz mentioned. as well as the number of organs in the person that have failed. The more organs, if your lungs have failed, your kidney is not working well, your liver is not working well, you're less likely to survive. But we pride ourselves in the fact that we bring people in the ICU because we think they're going to do well, we're going to do everything that needs to be done to get them out of the ICU. But that's how we get to know who is going to make it or not. The more organs that have failed, the less likely you're going to leave the ICU.
I think that you were talking to me a little bit before about people who respond to therapy, who have treatable processes, things that we could intervene. Tell us a little bit about it.
For example, with the organ failures, we have many systems, medications, and equipment that can actually help support those symptoms. For example, if someone does have kidney failure, we have methods of like dialysis that may actually help filter the blood just as a kidney would.
So you could do that for a short period of time. You don't have to have the whole dialysis for the rest of your life, you mean?
Not necessarily.
Right.
Many times a kidney injury could recover when the rest of the processes are recovering. In the same aspect, you mentioned something about the respirator. We have very advanced respirators now that can actually support people in their breathing very well. We talked about pacemakers. So there have been a lot of advances in medicine that we can help support the patient as they're recovering naturally. Their body has to, at some point, recover. So if we can support them through that time, and we've gotten better at that. So significantly, less people are dying in the ICU and they're surviving.
And I think some of the things you were talking about, especially with trauma, I know we had a congressman who was shot in a tragic incident in a ball field around D.C. And the idea that he was in the intensive care unit for such a long period of time really tells us that as long as you give people time to heal, a lot of times they'll be healing, especially after trauma. And our goal is to keep people as good as they can for a period of time. As a neurologist, that's something that I look for when I work with you guys in the ICU too, is to see how much brain function you have. Being a little bit prejudiced about it, I'm worried about someone's brain more than any other part of their body. And as long as their brain is functioning, we're fighting every moment to try to get people better, and that's so important. So let's do some general things. You guys also work in the hospital. You have some wonderful titles, take care of residents in the hospitals. When families go to the hospital, one of the biggest things that they're concerned about is how do they prevent an infection occurring in the hospital because of, their loved one comes in, maybe for a heart attack, maybe for something that's non-infectious. And they're so concerned. So many people are touching their loved one, and there's all kinds of things, and you can expound on them, like catheters and blood taking. How do we prevent infections in the hospital? And why is it so important to do it?
I mean, it's really extremely important for us to prevent infections. Just the individuals that come into the ICU are already, in one way or the other, prone to have an infection. They're very critically ill. They're immunocompromised compared to those that are not in the ICU. You have catheters that are put in to resuscitate these individuals. You have catheters in the bladder. You have them on respirators. You have IV lines. When you put any of those equipment in place, or catheters in place, you break the body's barrier in an individual who is already immunocompromised. So for us, in real estate, you say, location. In medicine is vigilance. You have to be very, very careful with everything that you do. And the other thing is hand washing. Those things have to be done. So you make sure the procedures that are done under very sterile conditions. Those catheters get in, you want to get them out as soon as is possible. You don't leave them in there any longer than this, 1 minute longer than they're supposed to be in place. The other thing that we do is those that have infection, we need gowns to get into the rooms to make sure that the infection doesn't get carried out of the room. Wear gloves, wear gowns. And as you go into the room, you wash your hands. You come out, you wash your hands. And when patients leave the hospital, they leave the room, those rooms are completely turned around, disinfected. And those are some of the ways that we prevent
There was
things that would
there were some recent
infection.
studies I think that were very interesting, talking about doctors with their stethoscopes.
Yeah.
If you go from one patient to another patient and don't clean it off, they can transmit it.
Yeah.
And I see you're wearing a bow tie.
Yeah.
And we've had this conversation before because I always have a difficult time tying my bow tie. But the idea that sometimes your tie dangles, even as a doctor, there are a lot of critical care doctors, especially in some of the Ivy League places around, will wear bow ties in order not to have any part of your garment touch a patient and possibly contaminate it or move around. Any thoughts about that?
No, that's definitely true. As a matter of fact, in some places, physicians really do not wear ties just because of that. But, I mean, you could still wear a tie as long as you tuck it in. And with the bow tie, it's a little bit easier. I don't have to do anything about it. But I wouldn't say people shouldn't wear ties. But
Let's talk about something briefly. All of us are always concerned. When I have patients who come to my office and I order blood work on them, everyone comes to me and says, do you know what, Dr. Perel? They drew up 7 vials of blood. I don't think I have any left in me. In the hospital, even specifically in critical care units, there's always the concern that too much blood is being taken out, that you're going to make them anemic. Are you vigilant to those kind of things in the intensive care unit? Do you think about that when you go on rounds? And I know you guys go on rounds 2 or 3 times a day. This is not 7 in the morning and then you're not back till the next day. What kind of things do you think about that people are out there thinking about that, to say that we are too?
Well, it's actually a very common problem, so common that there have been a lot of dedicated studies looking at anemia specifically in the ICU. We know that it's something that's very common. It happens for a number of reasons. When people are very sick, often their body doesn't produce blood as effectively, and that in combination with the amount of blood that we take actually does cause significant anemia at times. What we found from the studies is that the majority of patients really do well regardless, that the body has an extraordinary resilience to even significant levels of anemia, and that they more often than not don't require transfusions or anything related to that, so that they actually do quite well when given less transfusions.
And those small tubes don't have a lot of blood in them. And that's important
No,
to say.
they don't require that much blood in them. But we're concerned about the fact that at least we're taking out blood, and families and patients are also concerned. But the thing is, we take out just what we need for the tests that are required to be done. We make every effort to make sure that we don't take any more blood than it is needed. And you don't. Right now, you can do tests where you don't have to. You just get one tube of blood, and you do a lot of tests, so you get that all covered instead of getting a tube for each.
So before you're not going to be allowed back into the hospital tomorrow, unless you say who's in the ICU team. So tell us who's in the ICU team.
In the ICU team, it's a multidisciplinary team where you have the intensivist, the doctor, you have the nurses, you have the respiratory therapists, you have the pharmacists, the social workers, the dietitian, the physical therapists, all another healthcare professionals make up the team.
And I'll tell you 2 other people. One is the patient, of course, giving an accurate history, giving as much as we could find, and the last is the family.
Yeah.
I can't speak enough about family giving information, being enthusiastic. Tell me a little bit about the idea of sometimes when patients are in the ICU, it's a very sterile environment in multiple ways, no pun intended. But if a family wants to have music next to a patient, or pictures of a loved one, or when they were younger, or just their grandchildren, would you encourage it? What do you think of those kind of things?
I would absolutely encourage it.
Yeah.
I think that is important for the patient for healing. There are actually studies looking at the use of music as music therapy, and has been shown to improve people's outcomes. So I think any support, whether it be in the form of a picture, music, comfort, just tactiles, touch, all of that would be encouraged.
And what about families visiting someone? Say, as a neurologist, I see people in comatose states, meaning that they're not arousable. Do you think that the family being around the patient, and I do, you know, I truly believe that has a lot of input, a lot of help, even with people who are in very dire neurological conditions. But people who are sedated, people who are given medicines, what do you think about the family being around there and talking and being caring and loving? Do you think that helps?
No, it does help. We do encourage that a lot because the patients, while they might not be fully awake, it's good, they do hear, some of them hear, and it's good to hear a voice that they're familiar with. So we really do encourage that. As far as putting pictures is concerned, I wish everybody would come to the ICU to visit their relative and bring a picture of that person lying in the bed sick or sitting up in the chair sick, because they look very different, and it really humanizes makes you look at that person and not just
And that's a super point, because it actually helps the doctors, especially some of the young doctors and the medical students, and then and some of the younger people who are there, to see what they look like outside makes it a very different type of situation, different kind of a case. What about family interaction with you? If they have questions, is it something that is encouraged, not encouraged, talking to the family? And of course, the second part is honesty. If someone is not doing well, being very open with them. What do you think about that?
I think both of those points are very important. Open communication is definitely encouraged. From the standpoint, obviously, if someone is very ill, a family member is going to be extraordinarily concerned, and I think it can be very, very stressful for them, so that any information, be it positive, that you can give them, or at least you know, information that may be helpful or encouraging for outcome, I think is going to be good for them. In the same respect, you don't want people to have false hopes sometimes, and unfortunately, there is a part of it where we have to be as honest as possible and tell them, you know, what are the chances or what could happen. And I think that open honesty up front is part of a process. Even if the outcome is not good, it's a part of the process that they have to accommodate.
And I see that as the family being able to accept issues. And we really don't have time to talk about organ transplants and people who are brain dead without brainstem function. But that is a job that all of us do there. And that's really to help the whole community.
I'd just like to mention one thing about family. Right now we have in critical care, we have the A, B, C, D, E, F bundle, which the F stands for family. You cannot take care of a patient without the family. The family is extremely important, as Kid mentioned, and honesty is something that must be part of that relationship.
Our time's come to an end. I want to thank you all for being here. We're taking some of the mystery out of the ICU. The ICU is another part of the hospital where there are just more doctors, specialized doctors, nurses, more people, better ratios, closer ratios, 1 to 2, nurses to patients. And hopefully people who go to the intensive care unit will come out and do well. So thank you.
Thank you very much, Dr. Perel.
Thank you.